Good morning, everyone. Happy Monday. My name is Dr. Loree Johnson. I am a licensed marriage and family therapist who also specializes in reproductive psychology. I work primarily with individuals and couples who are managing all phases of their reproductive journey, and I have a particular concentration in infertility, trauma, and grief. And April is quite the month in the reproductive health community. This week actually kicks off Black Maternal Health Week. And the events that are happening this week are geared towards increasing awareness and improving outcomes for African American moms in particular. And then in 2 weeks, we actually have National Infertility Awareness Week. And this is where we're trying to raise awareness of infertility that affects millions of people worldwide. Approximately 17.5% of individuals worldwide struggle with infertility, or 1 in 6 couples. And with infertility issues continuing to grow, we're obviously seeing more of that in our practice. And so I'm going to be facilitating a day-long training with Pessy next Friday, April 21st. You might see the link on your screen and the QR code. And if you decide, I'd love to see you, because we're going to be talking a little bit about infertility, trauma, and grief, integrative strategies to help individuals and couples move through the grieving process, but also to improve their mental health. And I hope you'll join me as I share more about the infertility experience, the trauma that goes along with that process, and also just strategies, more concrete and actionable strategies that you can incorporate into your practice. And so I'd like to take a little bit of time today to answer some questions about working with infertility trauma in particular. I will be taking questions from the audience as well. So if you feel inclined, please drop your questions in the comment box. But Cole, I'm ready for the first question. How do infertility issues show up in general practice settings? And infertility issues can show up in numerous ways. And obviously, when individuals or couples are wanting to grow their families, infertility obviously is defined as when you've been trying to, grow your family, and you've been trying for under a year, for a year if you're under 35, or 6 months if you're over 35. But this process has caused, immense stress. And so individuals will start to seek out support as they navigate this really complicated process towards parenthood. And so you might start to see a little bit more kind of anxiety and depression, a lot more obsessiveness around fertility related issues that start to come up. And so, you might see partners really in conflict with each other. There are just different ways that might show up for them around what that infertility experience might look like. And you might notice too that it is more common for those in heterosexual couples. Cisgender women might be the ones that present to our offices first, because they're usually the ones, the fertility process is one that kind of happens to their body the most. The cisgender women are the ones that are the women that are going for most of the testing, all of the diagnostic testing that goes along with that process. And so that is usually one of the reasons why we start to see those individuals reach out first to attempt to access services, because it is a lot. When you're going through the diagnostic process, you're fielding a lot of those unknowns, and there's a lot of information to process. And so we do see a lot of support kind of happening from the male partner in those couples as well. But typically, we don't see as many men initiating services as the female counterparts do. But anyway, what you'll start to see clinically is just, probably this is one of the first life crises that the couple has had, and they're needing some help navigating the information, the medical side of things, the emotional side of things, and the psychological side of things. Next question. What are some facts about infertility? What are some facts about infertility that general practice clinicians need to know? So, unfortunately, a lot of the data that we have on infertility has been studied or normed on heterosexual couples. Now, we know that infertility, or that non-heterosexual couples do need to utilize fertility assisted reproductive technology to grow their families. But unfortunately, that data isn't necessarily as clear. But approximately 10 to 15% of couples within the US, or 1 in 8 couples, will struggle with infertility. And we'll see about 30 to 40% of within those couples is considered either what's called male or female factor. And then 20% or to 30% is combined. So it's kind of both of those, or it's kind of this dreaded unknown. And what we see within female factor infertility is mainly ovulation issues, hormonal issues that impact ovulation, but also structural issues. There might be some issues with the cervix or the uterus that need to be diagnosed medically to determine if it's female factor. And if it's considered male factor, we might notice issues with sperm quality and count and morphology, and also hormonal issues can impact male fertility, and also structural issues in terms of the male anatomy that could impact the sperm production as well. And while we have general data on the prevalence of infertility, we don't necessarily have clear data, like I said, on who it affects and to what degree. We do have some emerging data that states that African American women are twice as likely to experience infertility, but half as likely to seek treatment. But we don't really have clear data on other kind of racial and ethnic groups per se. Next question. When does infertility become traumatic versus stressful? And this is a great question because we know that infertility is incredibly stressful. And so the majority of patients, probably about 30 to 40%, I wouldn't say the majority, excuse me, but 30 to 40% of clients that are presenting to our therapy offices, or excuse me, to medical practices for infertility treatments, report some presence of anxiety and depression. And we do know that the longer that someone is involved in the treatment process, that the likelihood or the intensity of those symptoms increases or intensifies. So it's very stressful, and it impacts multiple areas of one's life. You have the emotional impact of infertility, the physical aspect of infertility, potentially going through multiple diagnostic testing. And if you're moving forward with treatments, then you are having to undergo, depending on, if you're the partner who's undergoing treatment or the person who is supporting the partner undergoing treatment, but it's still, something that both of, the couple is kind of going through together. And then you're also dealing with potential shots and procedures and multiple, I think multiple kind of steps that it takes that your body kind of goes through to deal with that, to kind of grow to kind of get to the point of even transferring or achieving a pregnancy. You have the relational stress that goes along with the infertility process. It can put a strain on your couple relationship, because you might have different ideas, or you might see that your clients have different ideas about how to proceed with treatments. You also might have different ideas of when to stop, take a break. So many kind of factors that impact the couple relationship. And one thing is very clear is that we never see the couple or members of the couple deal with infertility in the same way. And so part of the work is going to be really helping them understand the differences and kind of honor those differences in the process. The other relational aspects of how infertility impacts can be traumatic versus stressful is also how it impacts your relationships with friends and also family, because your extended network is on this journey with you too. So they're also feeling the relational stress. They're excited. They want this for you, or the client's family wants this for them. But also that can present an additional layer of stress. And then the psychological stress that kind of happens where, when you're not able to grow your family in the way that you hope and that you had imagined, then you're kind of questioning yourself. There's a sense of how you're kind of feeling this lack of self-confidence, or low self-esteem, because your body isn't behaving the way that it should. And then also there's the professional stress that can be present, where people are having to navigate going through this process, but still having to show up to work and pretend like everything is normal. And also, not really being able to, to kind of navigate both of those worlds, because there's probably this experience that they're having internally, that is one of stress, that is prolonged stress of this protracted journey, but then having to show up and then really be on and, put on this brave face. And so, while those are stress points, we really also want to make sure that we take into account how the client or the patient is reporting their experience of these factors. Because while we can agree wholeheartedly that these are stress points, the definition of trauma can be a little tricky. And obviously, I think a lot of us are familiar with the definition of PTSD and how that gets defined through the DSM-5. Um, and at the same time, I know that doesn't always link up with how we use the definition within the fertility community. However, it really is in the eye of the beholder, as people like to say. If someone is experiencing infertility as trauma, we need to take that perspective and really deconstruct what is traumatic for them. How are they experiencing it as traumatic? And really understanding and honoring and validating how it's showing up for them and weaving that into the clinical picture. So again, thinking a little bit more broadly about what constitutes kind of like a triggering event, because infertility is most likely the biggest crisis that individuals or couples have faced at this point in their lives. Next question. How does grief relate to infertility? I always say that you cannot talk about infertility without talking about grief. They are intertwined. From the beginning of our lives, when we think about when we're children, we have this idea of how we will, how our lives will unfold. And for some, that includes, growing a family. It means coupling and having children. And that might be based on experiences that we had while growing up that we end up internalizing. It could also be, not just from our families, but our communities and society that have, that has a very specific message about family and about parenthood. And I think we do believe, live in this pronatalist society where there is this expectation that, most people will couple and procreate. And so when you are on this journey and you've found your person and you've talked about how you want to grow your family or not, and when it doesn't happen the way that you expect it to, again, there's that life crisis that becomes, I think, the first kind of element of grief. And it's related to this level of disappointment around, okay, this isn't happening as easily for me as it did for my sister or my cousin or my coworker. And so there's this shattered kind of picture of how we expect our lives to unfold, or how we expect our reproductive journey to unfold, that isn't really that isn't consistent with the story that we wrote. And so next question. What are some therapy interventions that you find useful with clients experiencing infertility? As a clinician, I think you wear many hats when managing infertility, and we have to appreciate the nuances of working with this population. Patients and clients will come to us at various stages of treatment and also readiness for therapy. So I think it's important to first assess the client's needs for therapy. And is it going to be more exploratory, where do they need to talk about their options, or just need a place to process all of the information that they've just been given by their medical doctor? Is it more supportive, where they just need that emotional support? They don't really have other people to talk about their experience with. Is it more therapeutic? And that's where we might see a little bit more of the trauma work come in, where people are actively wanting to or needing to work on the trauma reactions that come up during the infertility process. Or is it going to be about decision making when you're dealing with infertility and you're also going through treatments? There is a very important part of the process that involves making decisions, very important decisions about what type of treatment to pursue. well, first and foremost, what doctor to to go see, or should you see a doctor to begin with, and then after that, what doctor to see, and then when you see their or hear their treatment plan, how does that fit? Or do you go see a second opinion, get a second opinion? Or if the treatments if you followed your doctor's protocol and it hasn't worked and you're concerned about if the protocol has been a good fit, do you seek a second opinion? Again, there's so many different steps and layers to the process that aren't just emotional, but that are very importantly kind of tied to the medical part of the journey. And so, again, needing space to talk about that and to have some concrete skills in place to be able to do that, some communication skills to help facilitate that. Or is the process going to be more crisis oriented? Because many of us in this community have faced clients who have come at a crisis point. They don't know what to do. They were years in, a few cycles in, and they're really at a crisis point about what to do next. And that crisis point, the intersection of that crisis medically with what that means for them emotionally. So again, needing to kind of assess what the client needs, and what would be most helpful for them, and to kind of facilitate that process, and that conversation with them is most important, I think, to kind of initially meet them where they're at and kind of start to kind of facilitate what's helpful for them. And again, depending on the client need, because of course that's going to dictate whether, again, they need more kind of stress management techniques or more in-depth kind of therapeutic work. But again, I still like to start with this idea of resourcing and emotional resourcing. And that is getting clients to start thinking about what are the qualities that they would like to have in place in order to handle, each stressful situation. And that resourcing can take place in a number of ways. So I think that would be one way that would be helpful to, useful for clients to experience infertility, but also within the couple. If you're seeing a couple, I think there's some clear communication exercises that, again, can help potentially create space for the couple to talk about their infertility struggle in a very concrete and safe way. Because sometimes what you'll see is one person wants to talk about their experience a lot more than the other, and that can create this a little bit more conflict, because the person that doesn't want to talk about the infertility issues, and they're obviously coupled with the person who does, and that creates that sense of tension. And so with some gentle and compassionate structure and communication exercise, again, we can help provide a little bit more support and guidance for these couples moving through that process. And next question. How do clinicians help couples struggling with infertility? So I think one of the first ways that clinicians can help couples struggling with infertility is something that we already do, and that is by validating the client's experience. Usually, when clients are coming to us for infertility support, you might hear them minimize their experience. And even with, I think, a lot of the information that has been disseminated from the medical community or what we might see on social media, we were doing a lot to dispel myths of infertility and trying to raise awareness by having people talk and share their stories. We know that there is still a sense of isolation that occurs, and a sense of comparison of what happens, between the individual's experience and what they see around them. And so that minimization might be, well, you know what, I don't have it that bad, or am I really allowed to be upset about this? And so validation is really important to start to help normalize that their experience is okay. And I think you also need to, and when you're doing that, you're going to get a chance to normalize this sense of grief, because I think this is the first time when they come into our offices, it's the first time for them to start to understand their infertility through a lens of grief as well. And I can't overstate that enough, understanding that their reaction is potentially born out of grief of how the story that they imagined or how they imagined their lives unfolding is not the story that is unfolding within them, and appreciating the difference between that. I also think that we help couples when they're struggling by providing a sense of containment and space to hold the client experience. And that safety is so imperative because clients often don't have that sense of safety and support elsewhere. And they really look to us to need, for that. So I think by providing a sense of validation, normalizing grief, and then providing a sense of containment, those are some initial ways that we can help couples struggle with infertility. And so, next question, thank you. How do clinicians decrease stigma around infertility? And I think there are a couple of ways that we can do this, both within the therapy or medical office, but also outside the therapy and medical office. So first of all, meeting clients where they're at, like let's focus on within the therapy medical office. It's meeting clients where they're at, providing very inclusive and non-judgmental space. Being validating and compassionate in our approach, holding space for them, and also around their intersecting identities that are contributing to their experience of infertility. And sometimes what we'll see in some of these marginalized communities is it becomes even harder to talk about the infertility experience because it's not talked about. It's already not talked about enough, I think, in the dominant culture, but it's within some of our smaller communities that we know infertility impacts. We'll see an even more difficulty in really honoring that. And so we want to make sure that again, holding space and honoring those differences so we can create, just that sense of validation, and it's okay to talk about those differences, and it's okay for them to show up, and that they can be safe, and we can handle, that conversation and hearing about those differences and how they manifest for those clients or patients. And then I also think that one of the ways that we do this is making sure that our language and our websites and what we put out on social media, that reflects a sense of adequate representation of communities that are impacted by infertility and grief. And so we want to make sure our language reflects that, our website, our office staff, even the magazines that we might have in our offices reflect different variations of our community. And so we want to make sure that our office represents not just us, but the clients and the patients that we see. And I think that is another way that we continue to kind of help decrease stigma around infertility and also grief. And there are other ways as well. I mean, I know that with Infertility Awareness Week coming up, there is Advocacy Day, and you have the opportunity to talk to legislators about reproductive rights and reproductive freedom and how that impacts everyone's access to that, at least here in the U.S. Like, as I know that PESI is kind of worldwide, but advocacy isn't necessarily for everyone. But if you feel inclined, there are ways to participate if that feels in alignment with your values. But I think that these are also some ways, just making sure that your office reflects who you serve is probably a good way to start. And I think those are all the questions that we have for today. And if you're interested in taking a little bit of a deeper dive, I invite you to check the link for my presentation next Friday, the 21st. There is a QRL code as well. And also, if there are any questions from the audience, I'm happy to answer those as well.
I think that's all for today, Loree.
Okay.
Thank you so much.
Okay.
Thanks for joining us.
Okay. Thank you.